if he's reading the question on behalf.
Thank you. Regarding the proposal to close the beds at Bishop's Castle Community Hospital permanently and give the strength of feeling of those in the neighbourhood, as demonstrated by the turnout at recent meetings with NHS representatives, how does the Council propose to represent the wishes of those affected by the likely permanent diminution of the NHS services in the neighbourhood? What pressures on Shropcombe is the Council able to bring to bear? I'll now read the response. Local members and the Council are aware of the strength of feeling surrounding the proposals and indeed share many of the concerns. Councillors have made a number of mechanisms to raise these concerns and have been in contact with senior representatives from the Shropshire Community Health Trust to arrange their attendance at the next Health and Overview Scrutiny Committee. There, members will be able to bring questions directly to Shropcombe senior representatives regarding the proposals to close the beds at Bishop's Castle Community Hospital and to receive an update on the local care transformation programme. This provides an opportunity to press for responses and raise the concerns of residents.
Thank you. And the second question is from Mr. Chris Naylor, who is somewhere behind me here. So over to you, Mr. Naylor.
Thank you, Chair. My question is on similar lines. At the recent public meeting in Bishop's Castle on June the 5th about the status of the community hospital, I asked both Shropcombe and the ICB to tell us what services were being delivered at the community hospital to help the audience understand the important role of the hospital for local patients. However, Shropcombe and ICB staff didn't seem briefed at that time to answer my questions. So could they now answer the following, please? What services are being delivered from the Bishop's Castle Community Hospital, both at the site and from the site on an outreach and in-home basis? What numbers of patients are helped through these services currently? I appreciate it may be hard to produce additional information as follows for the Scrutiny Committee on the 10th, but please could you in due course additionally provide a total number of patients benefiting from Bishop's Castle Community Hospital services as above over, say, the 12-month period to June 2023, and provide comparable service details and patient numbers for Ludlow and Bridge North Community Hospitals too. Obviously that latter part I could come back and offer as a supplementary public question in due course. Thank you.
Thank you.
The services being directly from the site. The South West Rapid Response Team have operational bases in Church Stretton and Bishop's Castle, and Admiral Nursing also use the hospital as a base from which home visits can take place. Concerns for requested additional data. We have requested this information from the information team, but this is going to take longer to collate and analyse than the timescales allow, so we will submit this as a supplementary information after the meeting.
Thank you. Item 5 is member questions. So I don't know who comes first. It's either Heather or Ruth, but you should take your pick.
Right, thank you. I'm interested that on the website, in fact, that answer isn't on the website, so it isn't there in the public domain.
It has gone through committee services, so
right.
That's.
Okay, because I looked at it last night and I thought this is anyway. If that can be processed, that would be very good. Right. Do you wish me to read the whole of my question? I will do, I think. Okay. The engagement. Sorry. The engagement process for the closure of 16 beds at Bishop's Castle Hospital has been beset with delays and problems. Could Shropcombe explain how they intend to analyse the digital and the paper surveys sent out when the closing date is the 17th of July and the board meeting to decide the bed's future and therefore the contract and handing it on to the ICB is the 3rd of August. The papers will need to be published at least a week in advance of this date. A full breakdown of the engagement results, and actually we will have even more because we've got another public meeting now on the 20th. will be required for the process to be transparent to residents in the 200 square miles of the hospital that the hospital serves. Paper copies have been late to be supplied, and by July the 3rd, there was still no free post address to return them to. I still haven't got a free post address, and I still haven't got the envelopes. And actually, I'm going to print some envelopes today, but it does mean that those people who are not digitally enabled will have to pay for the return. Posters and the public meetings have been made available very late for circulation, and face-to-face on street engagement has so far been restricted to just Bishop's Castle. They are yet to be rolled out over other areas of the 200 square miles. And this was, I wrote on July the 3rd.
And the response. Once the engagement period with the public closes, we have arrangements in place to do the final analysis and collation of the responses from all the different activities we have undertaken, with support from the independent companies who have been undertaking the survey and focus groups. Analysis of the early engagement activity and responses is already underway to ensure we have sufficient time to prepare and consider the required report. Once we have all the responses after the 17th of July, a report will be written to clearly show the activity undertaken and themes emerging from the responses. This report will inform the board's decision in August on whether Shropshire Community Health NHS Trust can and should continue to fulfil delivery of the contract for the inpatient bed service at Bishop's Castle that the ICB commissions. We are committed to making sure board members do have sufficient time to consider the engagement report thoroughly and conscientiously, as will be the case for all of the board papers. To support this, we have put time aside in diaries for board members to read, digest and ask questions about the report ahead of our public board meeting. We will do this as a seminar session for our board to make sure that by the time they discuss the issue at our August board meeting, they are familiar with and have had time to digest and consider the outcomes for our engagement activity.
Okay, thank you. Ruth?
Am I not allowed a supplement?
Go on then.
Thank you. I am really concerned that the level of distrust in our communities is such, with the haphazard nature of all of this engagement process from the start, when it was meant to start on the 22nd, we weren't even briefed until the 25th, and so on. There is a huge level of distrust, and we want to work as we have always wanted to work with you, to the good of the community. Working with us has proved really difficult because not even the public meetings had a date bounced off us so that we could actually be there. And in fact, I was away that week of the first meetings. So because the level of distrust is so great, I hope that all the paper copies and all of the digital responses, because people don't have their own data on them, will be available for the public to look at, so that actually any conclusions you've come to are clear and transparent. In the past here at the council, when we've done big consultations, that has been the case and people can look through them. And I really, really stress that we're at such a point in Bishop's Castle now, with 18 months of nothing happening, that actually it is absolutely vital that those conclusions and how you've come to them is absolutely vital for them to be able to see and understand that actually there has been no massaging of figures and data. Thank you. So who will respond to that, please?
Thank you, Helen, for your questions. Supplementary question. I'm sorry that you feel that you haven't been involved to date, and it is our intention to engage with the public first and foremost, but also with yourselves, and certainly appreciated the amount of support that all of the councillors in the South West and wider public have offered. Certainly over the last 18 months in terms of the recruitment process and the targeted recruitment days, and that is much appreciated. So absolutely take on board that more can be done in terms of working with you on this process. in terms of the report and the collation of data, we were working with two independent companies that have been conducting the surveys, both the online paper survey material, the face-to-face surveys, and the targeted focus groups. All of that data and information will be collated by the independent companies, so not done by the organisation, but by the independent companies themselves, and presented back to us. There is a seminar planned with the Trust Board members to go through that report and indeed all of the other data and information that will be reviewed in the round, so that they are well briefed in terms of the data, the information and the feedback from members of the public. Including the feedback and the questions that have been received and the responses from meetings such as this. So all of that and the report will be available on the website for the public to see and scrutinise in terms of that data. So absolutely take on board the question, Heather. So thank you for that.
Ruth.
Thank you. The inpatient beds at Bishop's Castle Community Hospital closed on a temporary basis in November 2021 due to staffing issues. Can Shropshire Community NHS Trust please confirm what attempts they have made to recruit both qualified and non-qualified staff for Bishop's Castle Hospital during the period November 21 to the end of June 23? Can the answer please include the following: the recruitment activity undertaken and the dates of each activity, the number of applications received by post and grade, the number of staff offered employment by post and grade, and the number of staff that accepted offers of employment by post and grade. Thank you.
And the response. The Trust has advertised regularly for registered nurses and the wider establishment using the NHS jobs process, whereby jobs would be open for a number of weeks with a closing date to allow for shortlisting. Remaining vacant posts would then be re-advertised. Given the limited interest in posts, the process was changed from April 2022 to a rolling advert, i.e. it did not close, and this continued to December 2022. Between November 21 and April 22, there were insufficient suitable applicants for vacant posts. The Trust decided to continue with the rolling advert and also undertook targeted open days and recruitment events. These events covered BCCH Ludlow and the South SW locality. In addition, the Trust commissioned an external company to advertise on social media platforms via a robust recruitment campaign, plus changes internally to recruitment systems to speed up the process of recruitment and onboarding of staff. April 2022 and August 22 events. 13 HCAs non-registered appointable, 6 people wanting 3-4 WTE permanent, of which 0.6 WTE then withdrew, leaving a net of 2.8 WTE. There were a number of appointable candidates interested in bank work but not permanent contracts. 3 registered nurses appointable, 2 permanent totalling 0.6 WTE and 1 bank only person. 2 B6 occupational therapists appointable, 0.4 WTE permanent and 1 bank only, who then withdrew. As you can see from the above, despite good attendance at the event, many of the interested candidates were non-registrants and interested only in very part-time hours, thus not enabling us to run a compliant 24/7 rota with the appropriate skill mix to safely deliver care. There were another 21 individuals indicated that would be attending the events, of which 9 did not attend on the day. 1 registered nurse was not appointable. 11 candidates wanted healthcare support worker roles but were not appointable. In July 22, in addition to the events and rolling advert, the locality manager for BCCH wrote to all previous registered nurse BCCH staff offering bank work, but there was no interest. There was also a leaflet dropped to Coverage Care Nursing Home promoting registered nurse job opportunities, but there was no interest. This was overseen by the ward manager for BCCH. Between April 22 and September 22, there was 1 applicant in response to the rolling advert who did not meet the job description and specification and therefore not shortlisted for interview. In October, 2 to 3 candidates were shortlisted for registered posts who had applied to the rolling advert, and interviews were arranged in late October 22, but the candidates did not attend the interview.
Thank you. Ruth, follow up?
Yes, thank you. Thank you for the comprehensive answer. There's a follow-up question, well, a lot of follow-up questions actually. But one of the things I'd like to ask particularly is sort of what incentives have you used to attract staff to Bishop's Castle Community Hospital? A rolling job advert when the beds have been closed, I would consider difficult to recruit to. I mean, you know, people want a career progression. Is it appropriate to apply to a hospital where beds are closed? What incentives have you offered, such as a golden handshake? Have you considered the regrading of staff to make it more attractive? And so finally, a lot of the, well, two finallys actually, also, have you undertaken overseas recruitment? But finally, a number of members of the local community did apply thinking they'd be offered jobs at Bishop's Castle because that was what was advertised. They were successful, and then the job offer was changed to Ludlow, hence the withdrawal of their application. And I think that's really disappointing because you had clearly a number of appointable staff who applied in good faith to Bishop's Castle and then were offered a job in Ludlow.
Supplementary questions, Ruth. I'll allow Claire, who of Nursing Workforce and Operations, to more fully answer some of that supplementary question. But just in relation to the staff that were recruited that wanted to work at Bishop's Castle, we have had a number of staff that have been recruited that are working at Ludlow in surrounding areas, some in the rapid response team, etc. And that was offered to them. But we have said that should we be successful in recruiting more substantially to the hospital, thus allowing us to open and run a 24/7 rota, then those jobs would be honoured. So for the staff that are working at Ludlow and the surrounding areas, that if the hospital became open, the inpatient ward became open, we still have services within the hospital, then those jobs would be honoured. Just in terms of some of the other incentives that we've provided to recruit, and obviously recruitment difficulties aren't just centred around Bishop's Castle, but we have some acute workforce pressures across the whole trust and indeed across the whole system. This is not an issue that is just relating to Bishop's Castle and Shropcombe. Our local acute trust and surrounding mental health trust are also suffering from workforce challenges, and indeed it is a national problem. There are 43,500 nursing vacancies across the country as we speak, which just demonstrates the enormous challenge that we have across the country, which is compounded in rural areas, we know. But I'll just hand over to Claire that can give you an insight into some of the incentives that we have provided.
Thank you, and good morning, everybody. So yes, in terms of incentives, we've got a very robust and happy to share with you a recruitment and retention improvement plan for our organisation, given the challenges that we've got, not just at Bishop's Castle, but right across the organisation at the moment as a result of the national nursing vacancies. And a lot of that includes development of staff, increased focus on providing additional resource and money for increasing their skill set, sending them back to university, which is what we've heard loud and clear from a number of our staff that are existing, and from staff that have left us as well recently in terms of reasons why they might have left the trust. So we know that that's really important for our registered nurses. In terms of the overseas question, Ruth, we have recruited internationally and we've had some success there, given the challenges that we've got with vacancies. The issue that we've got in being able to have international recruits at Bishop's Castle is we know from working with our acute colleagues, so Shrewsbury and Telford hospitals, who have done a lot of international recruitment in the last 3 years, that the pastoral package that you provide them and the support that they require for a good 12 to 18 months after qualifying here in England is significant. And so to be able to do that safely and to look after them properly so that we don't lose them, we need to make sure we have a core workforce already working within a particular team to be able to support them. And unfortunately, because the numbers are so small for what we need for Bishop's Castle, because the beds are tiny, that's proving exceptionally difficult for us. So whilst it would be wonderful to be able to do that, we know we can't safely do that and look after our staff and retain them as a result.
Hi, there's a point of accuracy, Chair, if I may.
Go on.
Just on the response, a point of accuracy, you mentioned a leaflet drop for coverage care nursing home, promoting registered nurse job opportunities. Well, a coverage care home at Bishop's Castle is residential, not nursing, as you probably found out.
Yes, obviously, and the ward manager that oversees that is also has a relative. She's the sister of the person that runs coverage care next door. But obviously coverage care has a much wider reach in nursing homes and availability of other people. So we'll be using their connections around not only the area, but also their wider reach in terms of qualified nursing staff. So, and there may be people that work within the residential home that do have registrations, but also healthcare support workers that might be interested in broader work across the system as well. So it was using every opportunity in terms of that local knowledge, but also they are, I believe and understand, one of the largest care providers across the Shropshire area. So using their connections, I think, was useful.
Okay, thank you. Moving on then, update on joint HOSC meetings. So, Sophie.
Thank you. So this is the update for the Joint Health and Overuse Scrutiny Committee. The last meeting was held on the 4th of July in Telford, and the main agenda item was a presentation from Gareth Robinson, Director of Delivery and Transformation for NHS Shrewsbury, Telford and Wrekin ICB. He was asked to present the learning from a review of the 23 winter plan and how this learning had informed then the outline plans for 23 and 24. From the presentation, members were interested in understanding more about the system, actions taken within primary care and the role for prevention, what it's had, and also the role it would play in future plans, so understanding more detail around that. On this basis, a commitment has been made by Gareth to deliver a briefing session with the members of the Joint HOSC on primary care on the 14th of August, with an agreement that a further update will be provided to the Joint HOSC in the autumn on the progress of the winter plan. Members identified that recruitment of staff has consistently remained a challenge for the system, and it was agreed that a briefing to look at this issue in more detail would be valuable, with the date of this briefing still to be confirmed. The next Joint HOSC session will be held on the 24th of October in Shrewsbury and is planned to be focused on the performance of the health system in Shropshire, Telford and Wrekin, understanding more about the national mechanisms for ensuring that the people of Shropshire and Telford and Wrekin are receiving the best possible services. Was there anything further that any members that attended would wish to add?
Yeah, there was just an interesting discussion about the potential for, I think the figure was 64 step-down beds proposed to be housed in modular units at Royal Shrewsbury Hospital. So there was a discussion around that, and that seemed to be something that was, a new suggestion. I think the committee, that raised the issue of whether there could be step-down beds at both Royal Shrewsbury Hospital and Princess Royal Hospital. But that was of interest to the committee in particular, together with continuing to see, and I know that work is being done, whether there could be increased provision over weekends to help freeing up some of the beds, which does, although there has been, some improvement by the sounds of things, does still need to be addressed.
Thank you, Kate.
Chair, if I may, on the modular units and additional beds, how will they be staffed, please? Is there a staffing recruitment plan for those?
I think it hasn't been confirmed, as far as I'm aware. It's in the early stages, but I think this would be staffed. This would be a different provision, so it would be not from the existing hospital staff pool. But that might be something interesting for us to look at as a committee, either at the Joint Hospital or possibly here as well.
Okay, that's something we can follow up on as it emerges then. Okay, thank you both. Item 7, local care transformation programme. So the whole remit. Go for this one. So Simon, do you start it?
Thank you, Chair. So I am, but I'm also just looking at the pack and thinking we sent 2 presentations through and only one's on the pack.
The first one relating to Bishop's Castle.
Yes.
Was available to be used if required for the answering of the questions. This one is specifically related to this agenda item.
We'll get it circulated. Okay.
No, it's more important than that, actually. Much more important. Had we known about that, then we could have asked questions around our questions. And actually, we didn't know, and therefore it opens up a number of other questions for us. I'm really concerned that we haven't had that so that we could do that.
Requested for it, we did send it to.
I'm not.
Yeah, I'm just saying that.
But actually, with the permission of the chair, when it comes to the next bit, which is transformation, I think we need to be able to see both so that we can actually ask the questions that are pertinent to us and the questions that we have already asked.
We'll do this one first. I want to keep them separate, but we'll get the other one sent as well, so we can revisit if you want that.
Yes, please.
Okay.
Roy and I don't have a clue who's across there because we're just new on the committee.
Okay. We'll do intros then.
I've got a glass upstairs.
So,
Are you okay, Chair, if I do make a start on that basis?
An intro.
And I was going to introduce myself. So I'm Simon Whitehouse. I'm Chief Exec with NHS Shropshire, Telford and Wricking, and I'm going to let colleagues introduce themselves as well.
Hi, I'm Lisa Keslake. I'm the Programme Director for the Local Care Transformation Programme.
Hi, I'm Gemma Smith. I'm Director of Strategic Commissioning for NHS Shropshire, Telford and Wricking.
And to my right.
Shelley Rantall, Director of Governance at Shropshire Community. Patricia Davis, Chief Exec at Shropshire Community NHS Trust.
Good morning, Claire Hobbs, Director of Nursing and Clinical Delivery and Workforce at Shropshire Community Trust.
Hello, I'm Gemma McIver, Deputy Chief Operating Officer at Shropshire Community Health Trust.
Thank you. So, Chair, colleagues, thank you. Just to come back to one of the points that Councillor Kidd raised earlier, in terms of the responses, both to the public questions and to the member questions, they have been published and they're online with the agenda and are the correct ones that Sophie read out. So they have been available because colleagues responded to those as well.
Even the paper ones?
Yes, and it's all online.
Oh, you mean the questions for this?
Yes, yeah.
It wasn't last night for us.
Okay. I just wanted to say it's available and it's there, but I absolutely recognise, which is why I raised the point at the start in terms of the 2 presentations that we sent through in terms of that. But let's pick up the local care transformation programme one, and then we can decide where we go from there in terms of the specific one around responding to the Bishop's Castle challenge. So firstly, Chair, let me say thank you. Thank you for the opportunity to come and have the conversation this morning. Thank you for the opportunity to have the discussion and debate with the committee around the local care transformation programme. And also let me recognise that many of the things we're going to talk about here will not be new. And will have been well rehearsed and will have been a lot of conversations about, and I make absolutely no apologies for that, because actually this is really important in terms of what this looks like and what we do going forwards. And actually taking the opportunity to revisit some of the evidence base and some of the available information around this, I think is important as well, to reset the conversation that we need to have, what this means going forward and what this looks like as we take this forward. Equally, I also want to recognise that many of the issues that we'll talk about here will be common and are across partners. So this is not just an NHS issue when we talk about this, and indeed how we deliver the local care programme. It is absolutely not going to be just an NHS approach, absolutely needs to be with partners. And when I talk about partners, I include voluntary community sector as well as local authority in that space. In the best COVID media briefing terms, could I have the next slide, please? And it might be worth just clicking on the cross bit and taking off the privacy policy piece, Sophie, if that's okay, sorry. It's okay.
Oh, it's not on my.
Because it's been shown from there. You don't need to crawl under, it's fine. So this is what I mean in terms of this being well rehearsed, and indeed Patricia and colleagues have already pulled some of this out anyway. If we look across the country, never mind just across Shropshire, Telford and Wrexham, you will hear on the news, you'll hear being talked about the current models of care is under pressure. Having an acute hospital-based model of care is not one that's going to be entirely sustainable going forwards. How we manage the local demand versus the complexity, looking after residents in the most appropriate setting in the most appropriate way is really important. And indeed the JSNA sets out really clearly across both our local areas, on our towns, and debated well at the Health and Wellbeing Board what those health and equality challenges are, the challenges of access and the challenges of provision to meet the needs of the population. And I'm sure we'll keep coming around the conversation, and indeed should keep coming around the conversation about the workforce challenges. The workforce challenges in terms of rurality, the workforce challenges in terms of the national debate around workforce, and of course now we've got the long-term workforce, the NHS workforce plan, but I'm going to make this really clear. If we don't work in partnership to also look at social care, also look at the voluntary sector, and look at our workforce challenges across that, then actually we'll be either robbing Peter to pay Paul or be shoring up one bit at the expense of another. None of those things do anything to improve the outcomes for the population that we want to serve and we want to look after. And we've talked a lot, and there's been lots of conversation about the cost in a financially challenged system, whether that be the local authority financial challenges, whether that be the NHS financial challenges. We are collectively in a situation where we're having to make some difficult decisions. How we make those difficult decisions, how we have the dialogue and how we have the conversation in that space is really important, and certainly one that we need to make sure that we do transparently, one that we do with clarity, and one that we do in terms of being able to articulate what the challenges are and what our solution is going forward. Next slide, please. So colleagues will have had these slides in advance, so I'm assuming people will have looked at these, but look, the evidence base here, the evidence base nationally, the evidence base internationally, and then the evidence base locally is really compelling. So we know there is a time and a place for people to be in hospital and be in a hospital bed, absolutely. But we need to keep that for as short as we possibly can so that they get the intervention that they need and then are able to get out of that hospital bed. We have a lot of debate about beds, but actually we've got a lot of beds across Shropshire, Telford and Wrexham. It just so happens that the majority of them are in individuals' people's homes. The evidence base internationally and across the country is really clear. Supporting people either to stay at home for as long as possible or to be able to get back to their own home and be looked after in their own home with the right wraparound care means that the outcomes for those individuals improve significantly compared with a prolonged hospital stay. We know that in hospital, if you end up staying in hospital longer than you need to, you end up deconditioning and you end up running the risk of requiring further long-term care when you come out, whether that be NHS funded care or local authority funded care, and that equally isn't good for the individual, not good for families, and isn't good in terms of the cost and outcomes for the system and for the service that we want to deliver. So the case for local care is really clear and is really compelling. The case in terms of getting people out of hospital in a timely way is equally compelling and equally really clearly evidence-based. And making sure that we've got then the services to wrap around and look after people in their own homes, whether that be pre-hospital admission or post-hospital admission, equally is really clear and really compelling, and the evidence base is there to back that up. Next slide, please. We've been round this conversation several times, but we're at a point now, because of some of the challenges, both we're seeing in terms of staffing wise, we're seeing in terms of system partner colleagues, we're seeing in terms of that demand and that complexity, that we have to get into a conversation that moves this from just being what do we talk about and what do we describe as a local care programme into what difference is this going to make and what does it look like and what does that get delivered as we go forward. I want to reiterate, and I've said this at public meetings that we've had with in terms of the big health and wellbeing conversations, that in terms of this model of care, this is not one that is predetermined that says it's going to look like this across the entirety of Shropshire, Telford and Wrexham. So reinforce that commitment to co-design models of care with residents, with communities, with staff, with colleagues, that one that has a focus on prevention and early intervention that supports people staying in their own homes for as long as possible. We have to get to a point where across Shropshire, Telford and Wrexham we're looking at how we support individuals with long-term conditions, whether that be respiratory long-term conditions, cardiac, diabetes, any of the ones that we know well. And indeed, we know rarely do you have an individual that has one long-term condition that doesn't have other long-term conditions. So that wraparound care and that intervention to help manage exacerbations and manage those conditions early and consistently is really important. We also know that if we don't do that bit well, actually what we end up with is a significant number of unplanned admissions. And if you have an unplanned admission into hospital, you're more likely to stay in longer, have more intervention, and then it makes it harder to get that supported independence when you get discharged to come out. Thank you for that. Thank you. And then the final point on this, and Patricia and colleagues and others have always started to talk about this really clearly, that actually from a member of the public's perspective or from a patient perspective, actually the view of one NHS is an important one. More importantly, the view of one health and care system across Shropshire, Telford and Wrexham is even more important. So how we talk about integration and what does that mean for individuals, I fear it's a word that was a lot, and we could ask everybody to write down what their definition of integration is around this table, and everybody would come up with a slightly different version of integration. But actually what we need is how do we make sure we tackle the boundaries between handovers in care, that we look across the interface where individuals feel as though they're getting passed around or are having to tell their story many times, so that we can deliver care in a way that is coordinated and focused on looking after those individuals in the best way possible. And we'll touch on, indeed Lisa will pick up in some detail, what that means in terms of virtual wards and hospital at home, because I also recognise there's an awful lot of lingo and abbreviations in this space, and if we're not careful we start talking about things that people say, well, actually what do we mean by virtual ward and what do we mean by proactive intervention and proactive prevention? So, you know, I hold me to account and challenge me if I start to fall into using the language in the wrong way. But at its heart, this is about how do we support residents to have the best life that they can for as long as they can, in a way that enables them to be as independent for as long as possible. That absolutely has to be our central drive in all of this. And we can't do that just with the NHS, just from a local authority perspective, or just from a voluntary or community perspective. It absolutely requires every partner, and when I say partner, I also mean patients, communities and residents, to play their part in this space. So the next slide, please. And at this point, I'm going to hand over to Lisa, if that's okay, Chair.
Thank you, Simon. So this slide shows the 5 programmes of work that sit within the local care programme. So these are transformation initiatives that require joined up working of all partners across the system. So I'll briefly talk through each one to bring those to life. So the first is avoiding hospital admission by providing community-based care, including rapid response. The second is implementing an integrated discharge team, enabling timely discharge home from hospital with access to the appropriate services in the community. The third is opening a virtual ward and expanding those virtual ward beds, enabling people to return to their home or the place that they would normally call home to receive subacute medical care that would otherwise need to be provided in an acute setting, so enabling that earlier return home. Developing our approach to creating community neighbourhood teams. So these are teams of multidisciplinary professionals coming together. So primary care, community care, social care, the voluntary sector and wider community-based services, delivering more joined up, proactive and preventative care. So this is how we wrap around our services together to some of our most vulnerable patients with multiple long-term conditions, where a more proactive approach would help to keep people well, independent and maintain their health and well-being. As part of that programme of work, really important that we work closely with Shropshire's prevention programme, as the neighbourhood teams will provide a really critical delivery infrastructure to enable some of that preventative work to be wrapped around people locally. The fifth programme is around further design of our subacute care and rehabilitation care. So virtual wards are one example of subacute care. There are other care models that we will be looking to co-design with our local communities as part of that expansion of community-based care. And that will involve looking at how we make the best use of our resources, including our community hospitals, our workforce, and how we look at the opportunities to develop community hub arrangements. So that will be a really important piece of work, and our engagement and co-development with communities will be really critical to that. Later in the presentation, Gemma Smith will talk a little bit more about our suggested approach for that. So of those 5 transformation initiatives, the first 3 have been in implementation since 2022 and are very much fully underway and looking to move shortly to business as usual arrangements. I'll talk a little more in a moment about virtual ward to bring that to life in a bit more detail. Those 3 areas of transformation collectively will help to stem the demand for acute services. So without those initiatives having been developed, the demand for acute services would have led to need for an extra around 150 acute hospital beds. But that care would be better provided outside of hospital, where the national evidence shows that by providing those services outside of an acute hospital, people have a much improved experience and improved outcomes. In terms of programmes 4 and 5, these are the areas where the programme is now looking to move the emphasis towards, in terms of ensuring that programmes 4 and 5 now develop at pace. The collection of all 5 of those programmes in totality support the overall aspirations of enabling people to stay well, stay healthy, maintain functionality and independence, receiving more care closer to home and indeed actually at home wherever possible, and ensuring that we are focusing our resources, both NHS and social care, around the needs of people in their communities. Next slide, if I may, thank you. And thank you very much. So a little bit more about virtual ward. So virtual wards are a safe and efficient way of providing care in people's own homes, supported by technology, and that this approach is suitable for people who require further subacute care that can be safely delivered at home rather than in an acute setting. So this includes people who may otherwise find themselves needing to go into hospital, so supporting avoidable admissions, as well as helping people to get home earlier when they have had a hospital stay. As colleagues may know, Virtual Ward is a nationally mandated initiative across the whole of the country, and there is an expectation that all systems will ensure a number of beds approximate to 50 per 100k of the population by December this year. Next slide, please. Thank you. So to date, there has been a really strong focus on frailty pathways for the virtual ward, with a strong process to enable step-up referrals from rapid response teams in the community, and also directly from care homes. Moving on from frailty, the focus has then been on respiratory conditions, both step up and step down. And presently, SAF and Shropcom are in the process of finalising the pathways for cardiology patients. Those three clinical areas will then branch into further pathway development as we continue to expand the virtual ward. Thank you. The graph here shows the levels of activity. So the red bars show the amount of referrals into virtual ward from step up. So these are people who would otherwise have needed to access services in hospital. And the grey shows the number of step down referrals of people leaving hospital earlier. And what you can see there with the blue line showing the target referral level is that the virtual ward is consistently above the target level of activity, which has been really positive to see. Thank you. So in terms of moving forward, as I said a moment ago, with some of those initial initiatives around rapid response, IDT and virtual ward moving to a very stabilised position and moving into BAU, we are now looking to move to the work on further subacute care and rehabilitation and the integrated neighbourhood multidisciplinary teams alongside the prevention model. So I'll now hand over to Gemma Smith to talk about the process for co-production.
Can we just pause there?
Of course, at any time.
From Heather on
Absolutely.
what she just heard, presumably.
Yes, I have. This. Oh, right. Thank you. It is a one-size-fits-all. It may be national, but have you done equalities and impact studies for the Southwest, where mobile phone signal technology, broadband, all of those things are a significant issue? And that, I think, is a major plank for us. There are other things that I'll raise later, but that one for us is so huge that actually 200 square miles of us will be totally without these services if that carries on, because virtual wards become very difficult indeed. And as we know, getting the staff across our areas is very difficult indeed.
I think I'll come in here. We're one of the major players within the virtual ward, and in fact, the delivery of the virtual ward is a partnership between Shropcom and SAF, the Acute Trust. So the Acute Trust are providing the medical oversight and supervision within those pathways, and it is predominantly our staff, our advanced care practitioners, who can be nurses, therapists, and others with additional skills to be able to give higher intensity type medical interventions to patients that require it. Out of the over 300 patients that have been treated, and in fact the step downs are increasing in number as we develop the team relationship across the consultant bed base and our staff, the number of step downs are increasing, which is really good. And as we work through those clinical pathways, in fact, in terms of the recruitment process around virtual ward, you may have seen some really positive national BBC reporting around virtual ward staff. One of the areas that we've been able to recruit has been in that area. It isn't just digital technology that enables the virtual ward. It requires physical interaction with the patient, i.e. go directly into their homes.
Very specifically to the Southwest, please, rather than the rest of the area, because it's the Southwest that has huge problems recruiting staff, as you just told us, and huge problems with the technical stuff.
I mean, I can't give you the total number of patients that have been treated across the Southwest from the virtual ward. That's something that we can sort of look at and provide at a later date in terms of the total numbers of step up and step downs from the virtual wards that have been in the Southwest area. It'll be smaller numbers because it tends to be smaller numbers, but out of the over 300 patients that have been treated by the virtual ward, there have been no readmissions to the Acute Trust.
Okay.
Can I just come back on that? I don't doubt that actually the whole process is a very good idea. Like, And actually, it's one of those motherhood and apple pie things, but actually with a lot of sensible stuff underneath it. My concern here is that we're rushing ahead with something that for many people can't be delivered, which will bring us back to another point.
Chair, if I may. So, Councillor, look, I think the points you've made are fair in terms of making sure that we can address those and respond to those. I think, let's be clear, it's not a one-size-fits-all. There is here's the programme of virtual ward that's national for the NHS. How we implement that and what that looks like is absolutely down to us to say how do we make that work and how does that look. And I think the second element of that is the evidence base of where this has come from isn't just suddenly let's come up with this in England and make it happen. Actually, some of the evidence base for some of this comes from some of that international evidence that I've talked about, where actually distances travelled, rurality is even greater than the southwest of Shropshire, because the principle behind this is how do you get that right support where you can't get that evidence base. Now, the recognition in there of what can we do with technology versus what makes sense with some of the telemonitoring that doesn't require the technology to the same way that you need the broadband, etc., to what can you do over a normal phone line versus what can you do with the right services and the right community hub, and what does that look like? I think there's a whole piece in this that we need to work through and explore. I think it would be we run the risk of potentially going down the wrong conversation and level of detail of saying what might the virtual ward look like in the southwest if we spend all of this time doing that, because this is about the whole of the local care. This was about how do we bring some of this to life. I recognise the southwest challenge, but equally, when I talk to colleagues in the north around Oswestry, when I talk to colleagues in Telford, there's a different level in terms of transport and health and equality. So across Shropshire, Telford and Wrekin, a responsibility for the residents across that area. We need to make sure that what we put in place meets the needs of the population, aligns back to the JSNA evidence that the Health and Wellbeing Board has clearly debated and clearly talked about, and that we do that in a way where we talk to people about what will work and what won't work. It's not about saying it must be like this.
Could I just ask you to remember that phone lines are going, they're actually being discontinued.
All right. Councillor Bentinck.
Thank you, Mr. Chairman. Mr. Whitehouse, this is clearly a welcome development, but set against a background of dreadful crises in urgent care. In any 1 week, there are an average of 150 patients in Shrewsbury and Telford Hospital without a medical reason to reside. And this statistic, although it varies a little bit between about 110 and 190 a week, is on average still 150 per week and hasn't really changed in the last 2 years. Part of the reason for this is the government and the ICS preoccupation with elective care, non-urgent care, rather than urgent care, with a huge amount of resources put in that direction. When the president of the Royal College of A&E has worked out that about 5 patients equivalent are dying per week in Shropshire from the inadequate urgent care. And while this model will be good for those with chronic obstructive pulmonary disease, the model on which it's based, it takes no account of heart attacks or other acute emergencies which require immediate access to urgent care. The other factor which has not been discussed and tends to go under the radar is a continuing problem of culture within health organisations. And so the Shrewsbury and Telford Hospital has, of course, been subject to the Ockenden inquiry, and with each week there are new organisations, new hospitals, new trusts that have these problems highlighted, most recently in University Hospital Birmingham. And so what is the ICB doing to effectively reduce the bullying and other unacceptable behaviours within the health system within Shropshire, when the latest staff survey of 2022 shows no change in the numbers of staff, the proportion of staff who feel they are bullied at work. Thank you.
Come on, Simon, let you respond to that briefly.
Thank you. So, look, Councillor, I think you raise 3 points in that that you've just articulated. The balance between the focus being on elective versus urgent, I would absolutely challenge you on that, to be honest, and say if you spoke to a resident who'd been on a waiting list for 2 years plus and had been waiting, and actually that started to impact both mental health, that started to impact on the number of times they needed to go and see their GP, the time that they then were unable to go and access work, and as a result then ended up attending the emergency department and accessing urgent care more frequently than if we dealt with that situation earlier and responded to that earlier. I think if you've got residents sitting in here having that conversation, they would have a very different view of that. And actually what our colleagues and partners have done well across Shropshire, Telford and Wrekin, I include staff and Robert Jones in this, is look to bring those really long waiting lists down successfully. There's more to go. It's still not to an acceptable point, and nobody would sit here and say that's acceptable. But I think we need to have the focus in both areas, actually. So I don't think it's about one being more important than the other. We need to bring those long waiting lists down, and we need to improve the urgent care piece. But we also know that if we can tackle that elective care waiting list and that backlog effectively, we'll do 2 things. One, we'll take out some of that attendance at general practice where people are going back to see the GP because they've not had that original condition dealt with. And 2, we'll reduce some of those unintended and urgent presentations that should have been dealt with if we'd dealt with that condition in the first place. On the second point, in terms of no criteria to reside and your patients that you articulated residents in hospital longer than they need to be in the number there. I think part of what we're talking about today, actually, and you know, I couldn't have articulated it better, Councillor, than you've articulated it, the importance of getting people to the right place in a timely way with the right pathways and the right management of that so that we can expedite those discharges hospital, and we can support individuals to get back to their own home, whether that be through a virtual ward route, whether that be with neighbourhood teams, whether that be in a supported approach in terms of community settings. I absolutely agree with you wholeheartedly that there's an area of focus there that we need to drive forwards, and I look forward to getting your support in terms of how we make sure then that these areas that we're talking about become successful so that we can really mobilise that to tackle that no criteria to reside bit. But that's not a one solution, it looks like this, or one partner looks like this. And on your final point in terms of the cultural challenge, I think, you know, it's not about what is the ICB going to do, it's what collectively are we going to do to make sure that we can look after our staff and look after our workforce, to keep them wanting to work in the NHS, in social care, for as long as we possibly can. How do we make sure jobs are ones that people want to do, that they are excited by doing that in what's a difficult and challenging environment at times? How do we make sure that we talk up the NHS and social care and domiciliary care so that we're positive about it and we promote it as a career, that we work with further education and we work with higher education around why working in Shropshire, Telford and Wrekin gives you an opportunity to really fly, and that then actually you start to live locally and you bring your family up locally, and we keep you in that space. So I think we've got an absolute collective responsibility, and collective I mean colleagues sitting around here, to talk positively around how do we do that, but we've got to make sure that those jobs are ones that people want to do, and that we look after our workforce in the best that we possibly can. I don't think anybody's sitting here and justifying and saying the staff survey from last year is where we would want to be. It's about the action plans that we put in place and the work that we do in that space, and how we continue to focus on those areas. Chair.
Thank you. No, I've got other people waiting. So,
I think others have been able to come back.
Councillor Elmer, Jeff Elmer.
Thank you. I'm pleased you mentioned the north of the county, because I didn't know why they're grabbing all the money and going to her area, because we do suffer in the north with lack of phone signals, etc. So I'd urge you to, as you've mentioned, Oswestry and that direction, please please continue to look at that. This sounds all wonderful, but is there any barriers to this? To help to expand this and roll this out, is the barriers financial or shortage of equipment or recruiting staff? And also, where are these phone calls going to go? Where's it going to be controlled? And what's the plans? What are the plans to expand the services? You're going to do the north from the south and the east, or the central and then move out, or what? What can we expect?
Is there more of the presentation which is going to include all that?
So the next bit of the presentation is more on the consultation engagement piece and what the timeline looks like. So perhaps we answer this question, Chair, and then we can pick up the consultation engagement piece, if that's okay with you, Chair. Okay. And I'm going to ask Lisa to pick that up. I think really good question, though, Councillor. Thank you.
Thanks, Simon. So I think, as we've touched on with some of the other questions, workforce is one of the biggest challenges, but also conversely one of the biggest opportunity areas. So I think it's a phrase which is often used, but this is a sort of once in a generation opportunity to really transform the way our workforce across health and social care and voluntary sector comes together to work differently, and how we can create some of that broader resilience that is required by working in those integrated teams. The journey to get there is challenging, and I think we've seen from many of the case studies, for example, have been developed by the King's Fund in other systems, show that it is a medium to long-term endeavour in terms of bringing those teams together, but that above all else, having that shared vision and shared commitment is critical. So I think we are looking as much as possible to utilise our joint forums and our various health and social care committees to help drive that vision and movement for change. I think you're absolutely right to your point about what is the route map. And there will be options about where we trial things, where we test proofs of concept, and how we spread and share the learning of what works and what improves lives for local people across the entire geography. And I think some of those choices and options about approach will be fed into our co-production and design process, which quite nicely segues into Gemma's piece about how we're intending to take forward that design process. So I'll hand over to Gemma Smith. Gemma.
Thanks, Lisa. So just moving on to consultation, engagement and co-production. So obviously we're really conscious that we've done a lot of co-production and conversations with the public so far, including the big and health and wellbeing conversation. Obviously the development of the joint forward plan, working with both SHIP and TWIP as our places and strategic delivery partners. So there's no intention to redo any of that. It's about taking that information and actually moving that on to the next stage, which is effectively co-production and co-development around the options of the model of care. So we, at this point in time, we are at the stage where we're gathering all of that information to be able to inform our next stage around the co-production piece. So what we want to work with yourselves and other partners in terms of what that would look like is really looking at actually how do we pull that together, how do we communicate and engage with the public, and actually how do we start to develop those options around delivery at a local level, whether that be through hubs or places. Really conscious again that there's been a lot of conversations around physical health in particular so far, but really keen to bring in mental health, voluntary sector, social care, housing and our communities into the next stage of that co-production as well. So really, before we start that stage, very much working with yourselves around how we pull that together, how we bring our stakeholders together, and actually how we start to work with our populations around that. Can you move to the next slide, please, Sophie? So just in terms of our process that we have to follow, so you'll see that we're at the beginning of that stage of pre-consultation. So the first stage we have to go through is developing a case for change and the vision. So we already have a lot of information that we've got and a lot of feedback together into a case for change, which then goes into an NHS England assurance process. It's the first step that we need to take to actually get the permission from NHS England to start that pre-engagement and that the options development as well. You'll see as we move through the stages that we pick up a number of things like the equality impact assessment, which I think's been mentioned a few times within this within the session, but also looking at the options and also the engagement, and part of that will pick up some of the risks and the challenges and the boundaries as well that we have as part of that. So we're very much at the beginning of that pre-consultation stage, and what will flush through that process will be very much things that we can do straight away, but there will also be things that potentially will be classed as substantive service changes, which would then take us into the NHS England assurance process. So very much at this stage looking around how we start that co-production piece and actually how we start to develop that case for change. In terms of timescales, we are looking to do that in the next 8 to 12 weeks around developing the case for change, taking it through our own governance processes, working with the system, and also working with NHS England, and then moving into that engagement with the public and stakeholders around the co-production piece. In terms of the next steps, so what NHS England will be looking at would be for us to take that case for change, our engagement feedback, and our co-produced clinical model into the clinical senate, which is, whilst it's classed as clinical, it's not, it's a multidisciplinary, multi-agency senate that sits as part of the NHS England assurance process, where they will assure our robustness of our plans and also what our clinical model and how that is a fit for our system and also against our population needs as well. So very much looking to do that in the next 6 to 8 months to get us to a point where if there's formal consultation that is required on any different aspect, that we would pull that into a pre-consultation business case. And then we would obviously move into any formal consultation. But at this point in time, we're not at a stage where we'd need to look to do that.
So one final point, Chair. I think, can we just acknowledge and recognise there's a real risk here of confusion and not of our own making, but because of the processes that we're set with NHS England. So there's absolutely a piece of work around the beds at Bishop's Castle that Shropcom are in and will then work with the strategic commissioner in terms of what does that mean and what does that look like. I absolutely recognise that. But equally, there is the bigger piece of work around the local care programme and what that model of care will look like going forwards. So some of this is in our gift in terms of what we do. Some of this equally is a nationally mandated assurance process for change. Clearly, the role of the Overview and Scrutiny Committee in this space is important in terms of determining what constitutes significant service change, and that's why coming here this morning is important to make sure that we continue to build that partnership and work in that space. I just wanted to recognise the NHSE assurance process versus what we need to do locally versus doing the right work for local residents is a bit of a complicated mix of here are the routes and here are the pathways. I can apologise for it. I can't change some of that. I can commit to keep coming back and talking about and presenting where we're up to, what does that mean and what does that look like, to try and make sure that we are going through that together and not in a way that says, why is this ending up being confusing and why is this ending up being, I feel as though it's a bit of a muddle.
Okay. Got a load of questions. Jeff, does that, you done? Okay. Kate, you were next on the list.
Yeah, thank you for the presentation. I had a question about the virtual wards. As I understand it, there's about 100 places at the moment at any one time, and there's around 20 of those that are people who would either hopefully have been discharged from hospital, who might otherwise have been in hospital, and I know that's a key part of the aims of this. So that leaves about 80% of the people in virtual wards who are in the community, and potentially some of those may well have ended up in hospital, and it sounds like I'm sure it's a really positive service for people. Nearly all of us would rather us or our loved ones were at home when they're not well, especially if they're not in severe acute distress. But my question is, has it perhaps created a service that wasn't available before, like additional community support? Has it perhaps not had the intended consequences that were originally set out in terms of, discharge from hospital into virtual wards?
Yeah, I'm going to try. I'll bring in colleagues that have been sort of dealing with the virtual ward on a daily basis. I think what we've seen is a huge level of positiveness. So rather than unintended consequences, I think what we're seeing is real positives around getting the patient back home or preventing them from going into hospital. As I say, out of the 300 patients that have been, over 300 patients that have been treated, none have been readmitted to hospital. And I think one of the main reasons is down to, as you saw in the presentation, that the longer people stay in hospital, once their acute episode is finished, or even during their subacute, there is a huge, particularly for older people and people who are frail, there's the huge potential of them becoming deconditioned. I have personal experience of that. A couple of years ago, my mother-in-law had a fall. She was, self-caring and able at home, had a fall, went into hospital in Cardiff for 3-4 weeks, and since then she's still at home, but with double-handed carers 4 times a day, lots of family input to keep her at home, but in effect she's sort of chair-bound and bed-bound. By getting people out of hospital as quickly as possible once their acute phase, or in the subacute phase, means that they're surrounded by their own environment. Rehabbing people, I'm still a registered district nurse. I did a couple of shifts last week. The importance of keeping people at home and keeping them rehabilitated at home unquestionably means that it results in people staying independent. So in terms of unintended consequences, no. I think there's more about what other support is required in terms of keeping people at home, in addition to the clinical care that's being put in, so that we can provide people with greater support to keep them there in the interregnum whilst they're still unwell. So I think there's still learning for us in terms of what other services that we can draw on to keep that individual supported. But in actual fact, I think it might be useful actually at another occasion to share with the HOSC some of the case studies of patients and individuals and communities and clinicians that have been through this process, just to demonstrate what the positive benefits are, not just in terms of clinical outcomes, but the more important outcome to the human being and their family.
Next one on the list is Roy Alcroft.
Yeah, just a couple of questions. Are you assured of the NHS will fund this scheme long term once you get going, and does that take account of things like involving mental health, force teams, ambulance services, GP practices, and increasing the amount of OTs that will perhaps make the decision as to whether a domestic premise is suitable for somebody to be left there for this virtual ward idea? And also, who's going to pay for any alterations, and who's going to do those alterations in housing that might not just be suitable but needs extra work? Now, somebody's got to pay for that. Is that the NHS or Shropshire Council? This is something that needs to be taken on board, and I'm conscious of the fact that money's tight and will be for quite some time. If the NHS trimmed down, NHS England, on this budget, then you're going to have to make changes to other services within the service you're offering currently. And I'm just conscious, with a team like the mental health falls teams and all the others I mentioned, there's an awful lot of cooperation there from different health trusts, and an awful lot of money that they're going to have to spend in order to make this work for you. Are you assured that you're going to get that support? Thank you.
So really important questions, Councillor. A couple of bits in terms of that then. So I think we've made funding available to start with to enable this to get off the ground and to build on the evidence base that's available, and that funding's been provided and been enabled within our system. We've agreed collectively as partners that this is a priority and it's important and that we take this forward. I think you use some really important language in your question though, because actually some of this isn't necessarily about everything needs to be new. Some of this is about how do we build on that co-production, how do we build on that collaboration, how do we build on that partnership, and we look at the services that are currently being provided across our system, sometimes really good services, but often in a fragmented and not joined up way, and how do we link those in and make sure that then we reduce that fragmentation and deliver services in a more coordinated and more integrated way. Often that isn't about new cost. Often we'll find that will be cheaper and will be more effective. And your final point in terms of how do we make sure this works for us, I would turn that question around. How do we make sure this works for the residents across Shropshire, Telford and Wrekin, and how do we make sure it meets their needs? So I think initial funding's been made available. We've recognised the evidence base around this. This is about not always new services. It's about linking and connecting services that are currently in place across Shropshire, Telford and Wrekin already. And it's about making sure that we've got that coordination to better meet the needs of the population that we've got responsibility for.
Councillor Kidd, Heather.
Simon and I have had conversations about all of this, and actually I think we are on the same side, because I actually think that there is a positive future out of this. It's just how it's implemented, when it's implemented, and the gaps that happen when you go from one process to another. That's the issue for us, whether that's in the southwest or whether it's in the north or around Oswald Street, or because there will be gaps everywhere, and it's those poor individuals that fall through those gaps that actually I think we're here to look after. So on the list of areas going into virtual wards, nobody has mentioned those people suffering from significant mental health issues who end up in acute beds because they've damaged themselves. There are all sorts of issues, and our mental health system across Shropshire is woefully inadequate in many ways. And until that's brought on and up in scale, we're not going to deal with a lot of that stuff that could be stopped from ever getting to the acute hospitals. And there is no viable step-down beds for those with mental health issues, apart from sometimes a police cell, which is totally inadequate. And also dementia. Huge issues. And we get those stuck in acute beds because there's nowhere for them to go. So this is part of the whole picture that we really do need to deal with. And it is a partnership thing. We cannot continue to use travel lodges for people to be in, and half a dozen modular units are not going to deal with the numbers that actually are ending up in travel lodges being not very well cared for, because it is not appropriate, and frequently they don't have in those rooms those things that they actually need for decent care. And it's a terrible, terrible indictment of healthcare across England, I think. But actually, when we have people who need that care in travel lodges, what I'm interested in here is real timelines and how they work, and actually how we're going to go through that. But I'm also interested in how you're going to take communities with you, wherever those communities are. Because a lot of the fuss around Bishop's Castle Hospital may well have been eliminated or actually quietened if we had worked with the community as we had asked all the way through. And I would really, really value people being brought together, not just in a big conversation, but actually where people can bring their ideas together, where GPs can bounce ideas off one another and so on. So it's part of your picture for NHS England, which I understand is very complex and not always the way we'd wish it to be. But actually, that is where we as local members can really come into our own wherever we are, whether we're in Ellesmere or Whitchurch or Bishop's Castle or any of the rural areas, because if people feel that they're part of the planning and that actually they're being listened to and not done to, which is the real problem, then actually we go somewhere and we get something much better out of the end. So what I would like here is a commitment to doing exactly that and working with us, not at us, because we are community leaders and we were elected to do exactly that. Comments, please, Simon.
Thank you, Chair. Thank you, Councillor. I mean, look, my starting point in this is, and there was a lot in that, so if I don't cover everything, you'll come back to me, I'm sure. But I'm going to hold on to the bit that you said, that we're on the same side and we want the same thing and we're going to work together in terms of getting to the right place in terms of that. I won't put words in your mouth and say fully supportive of the direction of travel we've articulated, but I think you were almost there in saying that. So I'm teasing, Councillor. Look, you talked about gaps. Let's just recognise now that currently there are gaps. And currently we don't deliver care in a way that we would always want to, and that individuals don't always get the experience that we would want. However, I'm really clear. I'm yet to meet a clinician, a member of the NHS, a member of the local authority, a member of social care, who doesn't go to work every day wanting to do the very best for the individuals across Shropshire, Telford and Wickham. Sometimes it doesn't work as we'd want it to, but many times, numerous times, actually, we deliver great care day in, day out to residents across Shropshire, Telford and Wickham. And I would want to thank the colleagues across health and social care, voluntary sector, for what they do day in, day out for delivery of that care. Equally, in terms of a process and how do we want to work together, then I think what you've heard us say is set out that commitment around where we want to try and get to and what that looks like and how do we want to work in that space. And equally, in terms of some of the pathways, to be fair to Lisa, I think she did talk about mental health and recognise, or Patricia indeed mentioned mental health and recognises the challenge in there. And it comes back to the conversation that answered to the question I answered from the councillor across from me. Part of this is about how we can't do everything on day one. And how do we add things in and build this a view of coordinated services that meet the needs of the population, coming back to what the GSNA talks to us about. Is this going to be, by this date, it'll be finished? Well, no, because we should always be looking to evolve and develop and take that forward. In terms of the engagement consultation, I think you're absolutely right to say, what does the timeline look like and set that out to be clear in terms of that. And in terms of how we might develop some of this, I think you've heard from Gemma that commitment to there's not one size fits all in terms of how do we do that work and how do we engage in that space. So that's probably not as specific as you wanted me to be, because there was quite a lot in, Councillor, but the commitment to be on the same side, work together in the best interest of the residents that we've got, work together to really support and talk up the staff that we've got across health and social care, and talk positively about the work that they do day in, day out, then you'll get me in that space supportive of that every day of the week.
If I can just come back. Absolutely, but it is that working relationship that we need to work on, because recently we felt done too. I think I will also join you in thanking staff across, because they do deliver to the best of their ability all over the place. And as you know, I have a daughter who is a nurse working in Shropshire. So it's not that I don't understand, but as a community leader, I will always hold you to account.
Go on, Peggy.
Some years ago, I was invited down to Sandwell to see what technology they were using. And I have to say, I've never forgotten it, because it was so impressive, especially the work they were doing with people that have got a dementia partner. And it enabled them, the carer, to not have to worry all the time. I'll never forget the one was a lovely old chap trying to look after his wife. They put alarms on all the doors so we could actually go in the garden. That meant he could keep looking after her, but no, she was safe. And it made such a difference. So I 100% I think technology is the way to go forward to help people. Not just the person who's calling, the person who's caring as well. That could make a big difference. So them being able to manage and that we're not putting them, the loved one, in the care.
I mean, I think.
Sorry. Sorry. Please make sure your communication is exactly as it should be, because the rumours that get around this county sometimes just beg a belief.
Picking up your second point first, heard, I think we've got a collective responsibility in terms of how do we communicate and how do we make sure. Now, to start with, we need to make sure we give you the information so that you can support that communication bit. But, you know, councillors, not just on this committee, councillors across Shropshire can absolutely have a really influential part to play to get those messages out differently and to talk about what's happening and what's taking place. I've got no issue whatsoever. So I absolutely fully accept the holding to account process that we do through scrutiny, that we do through democracy that sits in that space. But there's holding to account, and then there's the how do we do the communication piece and how do we talk about what's going on in Shropshire to better engage and inform the residents that we all want the best for across the patch. So dealing with that one first. In terms of your first point around technology, look, I think I agree. I absolutely agree. And there's absolutely a key part to play for technology, for digital. I don't think it's the be all and end all. It's not a perfect solution to say you do it in that, but doing that in the right way. I also think there's something here that actually that's not necessarily about a health responsibility either. And I don't mean that in terms of we pass the book, because that's not what I'm talking about. But actually, if we can get the right technology in early on to look after individuals and to enable people to stay in their home for longer, then you're right, that's better for those individuals, better for both local authority and the NHS. And whether that's on falls, whether it's on frailty, whether it's on dementia, you know, we need to get the right blend between what do we do around the technology approach, how do we get the right teams and the right people working in the right way, and how do we do that in a targeted way to meet the needs of the different populations we've got, whether that be the north of the patch or the south of the patch or the central part of the patch.
Thank you. I'm going to move things about a bit because David hasn't spoken yet, so I'm going to bring David in as a question.
Yes, thank you, Chair. And good morning, and thank you very much indeed for you colleagues for the presentation. And I understand we're at the very start of the process, and there's a long way to go. But it's quite clear to me, looking at this, that you're going to be relying heavily on the relationship that you already have with us as a local authority. And that in its turn, and I think the question may not be for you actually, it may be for Tanya on my left here, but are we as a council considering the implications for us that are going to come with this? Because you can't do this on your own. And if we're going to be putting resources into that, then maybe we're going to be losing resources from somewhere else. And it's that part of the process that I'm interested in. And maybe it's too early for you to be able to answer that. I don't know. Yeah. It's just where my mind's heading at the moment.
Simon first, before Tanya will chip in.
I mean, I'd love to answer that on Tanya's behalf, but what I was going to say, Chair, was it probably makes more sense for Tanya to pick that up.
Thanks, Simon, and thanks, Dave, for the question. So you're absolutely right. As a council, we are fully aligned to this way of working. You've heard me talk a number of times around the importance of supporting our residents in their own home. And as a council, the local authority, we do that really well. You know, we've got a really strong track record of supporting people to remain independent. So we've got our community teams working absolutely alongside our Shropshire community health colleagues in terms of avoiding admissions into hospital and absolutely supporting our residents to step down out of hospital. In terms of the kind of the next bit of the journey, we absolutely want to support our residents to continue on in supporting them independently. We've got the Better Care Fund, which is a joint funded between the ICB and the local authority, and there's key priorities in the Better Care Fund in terms of supporting people to remain independent at home, prevention, falls and discharge from hospital. And we are working through that through the Health and Wellbeing Board. So we've got a 2-year narrative that's just been submitted to the national team. We're just waiting for feedback on that. But the local care programme absolutely is a real strong emphasis within the Better Care Fund.
Thank you.
Yeah, and I think just to build on this, because it's been mentioned a few times, the GSNA, the proactive, the prevention work, and this would be amiss of me not to lead that in and build on what's already been said. I mean, there's a real opportunity in this, and we are pushing, you know, as we've said as a council, you know, that we are pivoting the whole organisation on prevention. We recognise that as a system and the importance of it, and this next phase gives us the opportunity to bring some of this work together. Primary care has been mentioned, the estates, to think of it in a different way, not just a step down in support, but actually can we look at this collectively, all together, that keeping people at home, helping prevent people getting unwell, or certainly secondary prevention is a really big important part of where we see the opportunity here, and we need to have those conversations now. The role of the voluntary sector and our own partners has been mentioned in terms of that support, and that's some of the work we're doing as a local authority, but we are working collectively with the NHS, and that's the bit that's exciting for me in this next phase of the programme, is to really start to shift that down, move away from some of that crisis conversations that we've had, and really be able to support people and build on what we're already doing. So I think there's an opportunity to make sure that we do that, we follow through on the needs through the GSNA that people are identifying, and we recognise the difference in our communities and building that and look at different models in different areas, and that is going to be absolutely critical, coming back to those and asking those questions about consultation.
Okay. I don't know who was first. Ruth was first.
Thank you, Chair. And I'd really like to say as well, it's really good to see references made for JSNA, because that's a really comprehensive piece of work, much wider than health. And, you know, credit to the council colleagues who've done that, but yeah, I'm glad you're using it. I just want to go back to your flow chart of pre-consultation and consultation. And I've jotted down some dates, 8 to 12 weeks, 6 to 8 months. 6 to 8 months, is that to the very end of the process for implementation? Or is it longer than that? Or is that 6 to 8 months up to NHS England assurance? I'm unclear on that. And secondly, it's good to see in that the equality impact assessment. But you've also mentioned in your presentation your hospital transformation programme. So under this sort of flowchart thing of pre-consultation and consultation, are there a number of steps relating to hospital transformation programmes? And will there be changes to community hospitals, not just Bishop's Castle? And if you've got the equality impact assessment within this high level consultation, why haven't we seen one for Bishop's Castle changes, please?
Thank you. So just in terms of your initial question, the 6 to 8 months is the full pre-consultation element up to the pre-consultation business case. So the case for change development, we're hoping to get through NHS England by the end of September, and then that will lead us into the engagement. And the reason for that is obviously we need to do that at a local level, so we'll need to make sure that's planned out. We'll need to make sure that we've got the correct information to feed into the clinical case for change, which then needs to go through the NHS England Clinical Senate. So a lot of the steps are around actually making sure we collate the information and provide the right case that goes through that Clinical Senate. So the Clinical Senate process, effectively, we set a terms of reference in terms of what we want them to look at, and then they pull together a group of at that. So what we're trying to do at the same time is making sure we're working through the NHS England process to make sure we've got dates lined up so that we can map the pre-engagement and the co-production piece through that as well. So effectively, when we get to the Clinical Senate stage, which will roughly be about 6 months' time, we'll have the case for change, and we'll also have the clinical models that are evidence-based that we need to take through. And obviously I'll be looking at the 5 tests as well to make sure we've had strong public and patient involvement, that we've co-produced, that the clinical model's robust, and any plans around beds are equally as robust, and we've got appropriate models in place. So a lot of it is more around the timescales around the process we have to follow, rather than us trying to stretch those timescales out. Then if we do get to a point where we have to consult on anything, then obviously we have to then go through the pre-consultation business case process with NHS England, which is normally a regional process, and obviously we need to work with yourselves on that in terms of any substantive service change. What we need to do as we go through, however, is there'll be a lot of things that we can do that we don't need to consult on, and actually are things that we can do locally. So some of that, as we're moving through, we'll be able to identify things we can implement without consulting, as well as anything that we do need to take through an NHS England process. So what we want to do is work with yourselves around what that process looks like to get to that co-production stage and what each of those stages are and what those dates are, to make sure that we can actually deliver in line with what we're looking to do. So it's, as we move through it, there'll be a lot of further things that fall out of that process. And equally, we'll then have to work through the prioritisation piece around how we roll things out and what that looks like.
Okay, thank you. That clarifies that bit on date and timescale. I think it would be useful to have this with some indicative dates along. So my next bit of the question was about the equality impact assessment, because they are critical, and rurality, age are just two big factors and protected areas that need to be considered. So my question is there one for the change at Bishop's Castle?
So in terms of the equality impact assessment, we did an original equality impact assessment when we temporarily closed the beds, and that indicated that was part and parcel of the original sort of decision-making process to close, in terms of temporarily, in terms of the safety element, and recognising what the impact was in terms of the local community, so that we could mitigate some of those kind of key risks through the introduction and expansion of the rapid response team, wider community services, etc. What fell out of the equality impact assessment was a sort of key metric around what would enable us to open the ward. That's mainly around staffing, given that the decision to temporarily close the inpatient unit was based on staffing levels. And those metrics around staffing are reviewed by our quality committee on a regular basis to see so that we're the trust board are informed in terms of when it could potentially open the beds. Obviously, we haven't been able to recruit, which is why we're in the position that we're in at the moment. However, we are going to repeat that equality impact assessment as part of the decision-making process on the third, which is about whether we serve notice on the contract for the inpatient services. So we will look at all of those kind of key aspects in the same way as we're looking at the results of the survey. So that's part and parcel. In terms of the wider equality impact assessment around any kind of future decision, long-term decision around the inpatient, that will be part and parcel of the process that Gemma has just described.
Okay, so if I may, Chair, is that equality impact assessment in the public domain from the temporary closure?
Yes, it is. It was uploaded onto the website. Just the decision, so that is there.
Can I just add, you talked about the service. You haven't actually talked about the impact on residents and the area. So does that impact assessment actually look at the impact on community? Because it's really important, and it should.
So the initial quality impact assessment did look at the level of risk, and that informed the decision, because we were in a position whereby we were running on 100% agency, and that's what enacted the original decision. What we intend to do is a much wider quality impact assessment, and indeed following the process that Gemma has just alluded to, dependent on the outcome of any kind of decision on the 3rd of August.
So just to pick up the points about the wider equality impact assessment. So should the decision be made to serve notice on the beds, then obviously the process will flip over to the ICB in terms of us pulling together our pre-consultation elements around that. As part of that, we'd have the equality impact assessment, a quality impact assessment. We'd also have a travel analysis as well. And we'll also look at things in morality. So we'd have to have a whole integrated quality, equality, access assessment as part of any business case. So that will then come over to us. So obviously we'll then be working as part of the process around co-production to also pull out some of those impacts, as well as some of that evidence at a local level, to actually feed into that process. So it's much when we get to the if and when we get to that point, then it becomes a much wider impact assessment and pulls lots of different elements in. But that isn't something that we would just do as an ICB. We would do that as part of a much wider stakeholder group to make sure all of that evidence is pulled in and actually assessed through a stakeholder group as well.
But surely, if we're looking at beds in Bishop's Castle, then the impact on the community should and must be part of your decision to give up the contract. We haven't seen that. And how have you done that? Because you only talked about the safety of the beds and so on just now.
Councillor Bennett, you were waiting. Can you be succinct on it, please, because we're running short on time.
Thank you, Mr. Chairman. And I'd like to just endorse Heather Kidd's thoughts about comorbidities and the additional resources that may be required. There are about a third of adults with comorbidities. So when people are admitted or assessed for virtual wards, there are other things that may be required. And most frequently, these are musculoskeletal or at least movement type problems. And so do you have a strategy for ensuring that there are sufficient therapists who are already in very short supply to be able to complement those professionals that you've already identified for staffing these virtual wards? Because otherwise the aims will be frustrated by the comorbidities.
Thank you. So I'll pass over to sort of Claire, who can talk about the establishment and the skill mix for the virtual wards.
Yeah, so just to say, the virtual ward beds and the capacity that we have there is only opened as and when we've got the staffing to be able to do it. So that's the first thing to say. The second thing to say would be that virtual ward is proving to be very interesting for professionals, particularly registered professionals, therapy and nursing. And indeed, we've been recognised regionally and nationally from NHS England in terms of the fact that, given we serve populations that are fairly rural as well, that we're doing considerably well compared to other areas. And so we're seen as a good news story, if you like, in terms of the fact that we are doing fairly well in terms of capacity in virtual wards. So from a safety perspective, we only open virtual ward beds as we've got the staff and the resource to be able to do that safely. And as it stands at the moment, because of the interest and the different type of approach of care that's being offered that's of interest to registered people, we're seeing that we are managing to reach that trajectory fairly well.
Confirm that you have adequate numbers of therapists.
Yes.
Thank you.
Good. Ed Potter, final word on this bit.
Yeah, thank you, Chair. I have to apologise, I'm new to the committee, so this is the area of health is quite new to me. So if the question seems stupid, I'm sure I'll get to grips with it eventually. But what I want to understand is the local care programme, All Age, how will you ensure that it includes support for children and young people? As we know that from a local authority perspective, this is an area of not insignificant growth.
Thank you. Absolutely. So one of the key areas and one of the pathways that we'll be next looking at is around paediatrics. So we already do quite a lot of integrated work with the local authority. So the Brighter Futures work, which was a pilot looking at integrated staff coming together within the Oswestry area and wider, has been well recognised in terms of the both the local authority, ourselves and the Mental Health Trust have achieved in relation to that cohort, and that's being now rolled out to other parts of the Shropshire area. But in terms of those children who've got an acute need, rather than being admitted to the acute trust to deal with that, we are looking or going to be looking at pathways related to children in the near future. And our medical director, Dr. Ganesh, is actually a community paediatrician, so he's got a real specialist interest in this particular area. There are examples around the country of people now looking at the paediatric pathways, and that's something that we want to be linked into and learn from in terms of best practice. But paediatrics and children's services are absolutely up there in terms of the next place to go in relation to virtual ward. But we are doing other integrated work, which doesn't relate to the acute elements across the local authorities and mental health trust too, which is equal to and as important in relation to the children's space.
Just quickly, your definition of near future and mine might be quite different. What sort of timescale are we talking?
Sort of next, well, the first, the 250 beds that are required per 50 per 100,000 of the population is in relation to adults, but we're working alongside the acute trust to look at how quickly we can establish the sort of paediatric. But I think we're talking about the next sort of 12 months in relation to the virtual ward. But actually, we're doing some really fantastic joint work in relation to children and young people in the other space around physical disabilities and mental health and learning disabilities, which is equal to, if not more important, actually, than some of the virtual ward. The acute element relating to children and children going into is relatively small, albeit that we do have a high number of kids going into A&E, so it's how we link in to look at how we're following those children up and supporting those families in the community. But it is an area that we're going to look at.
Thank you. Just moving on a step, I see we've got a bullet point 2, which is to set up a local care transformation task and finish group.
I think that could maybe be covered under the work programme.
That's on the work programme, that's what we're going to ask. Okay. Okay, we shall move on. I'm just curious, we have spoken a lot about Bishop's Castle already in the southwest. Would you be, and given the time, Heather, would you be happy to circulate that Q&A document that was talked about earlier?
I think that would be very useful for us to see. I would also like to point out that we are concentrating on Bishop's Castle because something significant is happening in our area, and had it been in Whitchurch or any of the other community, or Ludlow or Bridgenorth, then we would be doing exactly the same thing, and we would have local members doing exactly the same thing there. So this is because we have a situation that needs to be really carefully looked at, as we would for any area of Shropshire. Thank you.
Absolutely. I wasn't belittling, I can't say that.
I'll belittle Bishop's Castle.
That's the one. Okay, so Simon and the teams, thank you very much for your input today. It's been a useful experience, I think, on both sides. So hopefully we can reconvene at a later date and get updates as we. Thank you. Item 8. Rurality. I wonder what we're going to talk about.
It fits really nicely with what we've just been doing. We have
task and finish group update.
A task and finish update on rural proofing, which will be applied hopefully to both health and social care, but may also be useful for other areas of council work. So I don't know whether you remember having this set up, but actually it was set up to understand what rural proofing actually means for Shropshire, to set line what rural and rurality means across the area, and to look at those inequalities. Certainly we've had a lot of work done from the JNSA, which of course thankfully has been done for the Bishop's Castle area. Sorry. But also just looking at how we work through that and so on. So we've had a number of meetings now, and the first session on the 19th of May really looked at the desktop evidence, everything that we knew about it so far, and looking back through committee's work and so on, so that actually we could begin to look at who we wanted to interview in the future, where we wanted to go with all of the work. 2 further sessions have happened involving council officers. Her name's escaped me. Lois Dale was really useful, and actually various challenges around her work were I think useful to her as well as to us. So that was a really informative session that we went on to do. That was and went on to inform other things. We now have another session on the 21st of July and an all-day session on the 7th of August. And we've got lots of people now coming forward to actually take part in giving us that evidence, which is really quite encouraging. Because when Sophie has been asking the people that we actually outlined, they are actually saying yes and coming forward quite quickly and wanting to take part in it. So I think it's an issue that probably touches many people now, and we really do need to understand it. So we were trying to understand the public's experiences on the 21st, but actually we've got a whole range of other people coming on the 7th. We then will have a 3rd session planned for early September, and then we will go on to form our recommendations from there. We ought to have that report written up to share with HOSC on the 20th of November, and then it will go to Cabinet on the 13th of December. But it's been fascinating so far, huge input from people. I think it's a difficult time for everybody to take part, but we're having more and more people dipping in and out of it, which is really useful. So I think the sessions on the 21st and the 7th will be really useful. We've got people from a huge range of areas coming from the Rural Services Network. We've got people from health in different guises. We've got social care. We have all sorts of people from the voluntary sector. So it should be well worth doing. Thank you.
Thank you. Item 9, we've got the work programme. So it has been circulated with the agenda, part of the agenda. So we just need to adopt that. Sophie, I think you need to say.
Oh, I'm sorry. Thank you. Just briefly, thank you, Chair. So yeah, this document hopefully shouldn't have contained any surprises for anybody, as we've really tried to build on learning from the previous years, so that it has been a inclusive process to be able to include the areas that members were interested in. The way the document's set out means that hopefully it can then translate directly into terms of reference for the different work topics. So it's it's clear in terms of its objectives, the work being carried out, and the beginnings of how that can then be measured. But I think that's one area that we acknowledge will need to be refined as the work continues. And that. So yeah, in terms of the work that's underway, as we've already heard from Heather, there's the rural proofing in health and care task and finish group, which the committee already has underway, and you understand the timescales then around when that will be completed.
But I forgot to tell them, of course, we've got a very nice colourful timeline that you're all welcome to have a look at.
Thank you. So yes, what we're really looking for today at the meeting, today's meeting, is to adopt this work topic programme if you're happy to do so, and then begin to think about the next piece of work that the committee may like to commission. And as was referred to earlier, there was a proposal that may be the topic on the local care transformation programme, based on the fact that we'd received that presentation today.
Yeah.
Thank you.
So I think we need to set that task and finish group up officially. So is everyone happy that we go on and set that up? Yeah. Nobody's objecting. Okay. Is that a question?
Can I just ask, sorry. I'll just ask a question.
Yeah.
Thank you.
Go on then, David.
The mental health section, which I'm very much looking forward to being able to contribute to, particularly from schools aspect. I was just wondering when, does anybody have a feel for when that might get underway? So I can make sure that, because I'd like to volunteer for that, to make sure I've got sufficient time to do so. It doesn't matter telling me now.
Yeah, okay. We'll keep you in the loop then, David. Yeah. Bernard, do you have a comment? Or?
Thank you, Mr. Chair. Yes. During the time of setting up the work programme, on a number of occasions we discussed urgent care, which is an urgent issue for the council as well as for the local integrated care system, but isn't mentioned at all on the programme.
Cool. Sorry, sure. I was probably say the same thing. Sorry. I think we also, sorry, it's flashing. Discussed previously that urgent emergency care was being looked at the moment through the HOSC and also through the joint HOSC, and there is an absolute acknowledgement that these topics, because of the nature of them being system wide, maybe that they do absolutely, have elements within different committees and that recommendations can be made across the committees. So just to reassure that absolutely it's not something that's been forgotten, but it's being scrutinised within another committee at present.
Kate.
Thanks. Yeah, I unfortunately missed the second session on the work programme, but in the first session, we did discuss the possibility of looking at alcohol and drugs, and there are, increases, unfortunately, in very high drug deaths and alcohol deaths as well. And it's also an area that's had a significant investment recently with the drug strategy, the government strategy. So I just noticed it wasn't kind of explicit within the work programme, but we haven't looked at alcohol and drugs for a while on this committee, so I was just wondering whether that could be included.
What this does not include is the identified briefings, so that at the moment had been agreed to be included as a briefing, and with the potential that those briefings, once made, may lead to further work and actually becoming a topic. And because this document is completely owned by yourselves as a committee, once things like those briefings have occurred, if it does feel appropriate that there needs to be a rejig or an additional topic that can be included. But at that meeting, I think it was fair to say it felt appropriate that began as a briefing rather than going straight into a work topic.
Yeah. Okay. Mitchell.
I think I was just going to add that it might be helpful to put the briefings on at the end so people are very clear, because the timelines will then affect the follow-up into the next committees.
Yeah, I think we can do that. Be helpful. Yeah, okay. Right, so that just leaves, get the right page. Date of next meeting. It should disappear again. 20th of November, there you go. So thank you, everybody, and this meeting is now closed. Thank you.